Welcome to conference. I hope you're having a good start to your few days in Birmingham. My name is Robert Eade. I am Head of Health and Social Care here at Policy Exchange. And we're really pleased to be putting on this fringe event in association with our partners, the Royal College of Surgeons of England versus Arthritis and the Independent Healthcare Providers Network. And it is entitled, On the Side of the Patient, What Are the Conservative Party's Plans to Improve the NHS? And we've pulled together, I think, a stellar set of commentators and experts, which I will now introduce. So immediately on my right-hand side, we have the Right Honourable Robert Jenrick, who is the Minister of State for Health. On his side, we have Chris Smythe, who is Whitehall Editor of The Times. And then on the far side, we have David Hare, who is Chief Executive of the Independent Healthcare Providers Network. To my left, we have Deborah Alsina, who is the Chief Executive of Versus Arthritis. And then on the far side, Professor Neil Mortensen, who is President of the Royal College of Surgeons. We're going to ask each panellist, as is convention, to give a few opening thoughts. We're going to keep it punchy because we want to get you in for questions. So I'm going to give them about 3 minutes to set out their views on the subject. So without further ado, I will hand over to the Minister.
Thank you. Well, it's a pleasure to be here. Good morning, everyone. I'm delighted to take up this new role just a couple of weeks ago and in many respects to return to being involved in health and social care. I spent 2.5 years as Secretary of State for local government during one of the most tumultuous periods for health during the pandemic, working very closely with local councils and with social care providers across the country and helping to deliver some programs like shielding, which try to support the most vulnerable in society and which I think as a government we should be proud of because they achieved a lot in a very short period of time. And so to return to this issue and now to be supporting Therese, the new Health Secretary, it is a great pleasure and very important, a privilege to do. I think it's worth saying from the outset that COVID is still with us. COVID cases are rising. They rose by 50% last week. And the long shadow cast over the health service by the pandemic remains. And it would be, I think, foolish of me or any incoming minister to be anything other than straightforward with you and with the general public about the challenges facing the health service. I think it would also be to do a disservice to the workforce not to acknowledge how challenging the environment is that they're working in and to put boosterism to one side and to say that we are going to try to work closely with them in a partnership to try to work to ensure we tackle some of the challenges that are facing the health service in the short term, and they're very significant. I think most independent commentators would say that this autumn and winter is going to be one of the most challenging that the NHS has known in its history, but also to look to the future and to provide some hope and confidence that we can put the NHS on a more sustainable path. And that comes into a number of areas to me. One is the workforce, which must be the most challenging area now. There's at least 10% vacancies within the NHS, arguably more in social care, and we need to take a longer-term view as to how we can retain and recruit those brilliant professionals that keep the health service going, and there's some challenges and questions ahead for us as to how we can do that, and we may get into that in some of the debates here this morning. The second thing I think is to acknowledge that the NHS was created in the 1940s as a national endeavour, and the principle behind it, the deep conviction that healthcare should be provided free at the point of delivery, remains with us today and is an unshakable commitment of the government. But the way in which that is delivered does need to change. And as Tony Blair, I think, said recently, the NHS is a service, not a religion, and we need to ensure that we're championing patients and ensuring that the NHS is a driver of innovation, of research, of more patient-focused care, and that there is a closer partnership between government and healthcare providers and between healthcare and the patients. And there's a number of ways in which I think we can do that in the years ahead, taking advantage of incredible technological improvements with life sciences, with data and with technology. And that will be a great challenge, I think, for us as a set of ministers to help to guide the NHS through one of its most challenging, if not the most challenging winter that it's known, whilst also having an eye on the future and giving both its workforce a sense of hope that we have a plan to support them, to grow their number, and to make sure that the working environment that therein is better, but also that through technology, through life sciences, through learning the lessons of the experience we've been in COVID, we can actually build a better and more sustainable health service for the future. But I'm very pleased to be here, and I look forward to diving into some of these questions in more detail in a moment.
Thank you. It was really encouraging to hear your comments on the long-term vision for the workforce. Obviously, that was something that was a source of much debate during the Health and Care Bill. Is that a signal that this government will take a new approach compared to the Johnson administration, do you think? Is that what it's trying to signal?
Well, the previous administration was focused on the workforce. If you remember, we stood for election on a set of manifesto commitments to significantly increase the numbers of doctors and nurses in the service, and I think it's absolutely critical that we meet those commitments. The nurses' commitment, for example, we are very much on course to meet, but we are seeing very challenging circumstances with retention, and we as politicians need to acknowledge that and think of ways in which we can improve that in the context of a very challenging financial picture and cost of living crisis. I do think that we need to take a longer term view, and that there is validity in some of the arguments that we've heard recently in Parliament, advanced by Jeremy Hunt and others, that if we are blessed with a National Health Service, one thing it should deliver us is long-term planning for the workforce. And as a country, I also think we can't keep relying on importing doctors and nurses from overseas. That's obviously very significant. We're actually doing well at that as an NHS, particularly in the sphere of nurses, but we've got to grow and develop more of our own talent here in the UK, and that's an area where I will certainly be thinking quite carefully in the months ahead as to whether we're able to do that.
Great. We can get into how we'll pay for it as well, hopefully, in the discussion. Deborah.
Thank you. So thank you. Great to be here this morning. And so to be on the side of the patient, we actually need to understand... Okay, let's try again. That's better. All right, lovely to be here. Take two. So I think to be on the side of the patients, we actually need to understand patient need. And that's, of course, a multifaceted, complex position. But I want to talk about people with arthritis and musculoskeletal conditions. So arthritis and musculoskeletal conditions are the single biggest cause of pain and disability across all 4 nations of the UK, with 20.3 million people experiencing those conditions. They affect people of all ages, so there's a multitude of different needs. So, for example, there are 12,000 children and young people living with juvenile idiopathic arthritis. We also have to remember that deprivation plays a really big part in people's experience and outcomes. So if you are in the most deprived fifth of the UK, you are twice as likely to develop arthritis or musculoskeletal conditions. You're more likely to be living with multiple conditions, and you're more likely to develop them 10 to 15 years earlier than the rest of the population. Arthritis is also predicted to cost the NHS cumulatively over the next 10 years £118 billion. So it's absolutely essential that our interventions are timely and effective and really meeting patient need with a strong focus upon prevention. One of the key challenges, as we all know at the moment, are waiting times. So at the moment, there are 768,000 people stuck on orthopaedic and trauma waiting lists, 52,000 of them for over 12 months. And you know, as people wait, they are being disabled, their pain is increasing, and their mental health is declining. People are losing their lives and their independence and losing the ability to live the lives that they want to live. So I think we need to do 4 key things. The first thing we need to do is we need to bust the myth that elective procedures such as hip and knee replacements are in any way optional. They really are not for the people who need them. One of our supporters described her 2-year wait for her hip operation as like stepping on jagged glass every day. We need to protect capacity. So great to hear the Minister talk about the need for a long-term workforce plan. I agree. Some of us have seemed to have been talking about it for a very long time, however. But it needs to be more than just a health workforce plan. We need to be talking about health and social care. We cannot fix the NHS without fixing social care. And we need one long-term, fully costed, time-bound plan, and we need it now. We also need to be protecting elective orthopaedic capacity. So we'd like to see a ring fencing of orthopaedic capacity and staff to be able to deliver and reduce that backlog. We must facilitate choice for people. So we absolutely support the development and delivery of surgical hubs. But we have to remember that even before the pandemic, people were struggling with costs and with travelling further away. And for some people, that's just not possible. So we need to really be thinking about what are the wraparound services that are in place to enable people to access the surgery they need when, where, and how they need it. And finally, I'd say we need to support people to wait well. That includes really effective prehabilitation for people so that they can access surgery when they're finally called, but also good rehabilitation. There needs to be good pain and mental health support for people, with individuals having personalised care plans for those who are waiting over 6 months. And people need clear information to know how long they're going to be able to wait. And I think if we could put some of that in place, we might actually have the opportunity of really being on the side of patients. Thank you.
Thank you, Deborah. Neil.
So, microphone? Yes, thank you very much. Good morning, everybody. Good morning. Thank you very much, Robert, for inviting me to the panel. This is a really important moment, I think. I'm speaking on behalf of the Royal College of Surgeons of England, but I'm really speaking on behalf of the whole theatre team. We can't operate without anaesthetists, theatre staff, etc., etc. You've heard of the pressures. We think now that around 1 in 8 of the population is either waiting to be seen or for treatment, and that this figure is likely to get worse into March 2024. This backlog, the B of the ABCD, is one of the biggest challenges for the government right now, and this is a unique opportunity, I think, Robert, to show you really are on the side of the patient. So, as you've heard, patients on waiting lists don't remain the same, they actually get worse, they have bigger problems. Operations are more difficult when they eventually come to surgery. Cancer surgeries are more difficult when patients eventually come to surgery. So wait lists aren't just routine patients waiting for routine operations. It's much, much more nuanced than that. We see particular problems with wait lists around different parts of the country. We're in Birmingham, the Midlands, and the Northwest and the Northeast have particular problems about long waiting lists. And with 50,000 still waiting on waiting lists to 18 months, this is a huge, huge problem. And of course, it undermines our public's faith in the NHS. In the King's Fund report on British social attitudes last year, it showed a fall in 15% in satisfaction with the NHS to 36%. So tackling all these inequalities is what we've been calling for. We've been calling for more surgical capacity. We'd like to see a surgical hub in every integrated care system around the land. Now, you've probably heard about surgical hubs. What are surgical hubs? Basically, it is ring-fenced surgical capacity. Very, very important during COVID because it meant that patients could have safe surgery without getting the infection. But as we begin to come out of COVID, and as you've heard, we're not out of it yet, we still need to have those ring-fenced facilities. In 2018, just because of flu, surgery, elective surgery stopped for a month. So this isn't anything new. Every year, up until the pandemic, we've been struggling with the waiting list slowly getting bigger and bigger, rather like a river silting up. So these surgical hubs can come in all shapes and sizes. They can be a pop-up theatre in the car park. They can be a major development on an existing hospital site. And we're really, really pleased to see that government has incorporated the idea, the notion, the plan of surgical hubs into their philosophy. One of the main obstacles, clearly, to establishing surgical hubs is funding. We were really pleased to see in the target investment funding arrangement 1.5 billion towards building new facilities around the country. There are 91 hubs already designated, operating or about to, and there are 50 new surgical hubs on the way. I was delighted to read in the paper over the weekend that Newcastle has just opened a surgical hub, 25 million. Fantastic for high volume, low complexity surgery. But of course, now we're worried that having agreed this is a great idea, put the funding in, we're into a new age of financial stringency. We're really, really concerned that with rising costs in the NHS sector, both for heating and for energy and for staff costs, that somehow that money might leach away, which would be a tragedy. Now, of course, part of the problem with a hub is you've got to staff it, and we've already heard about the workforce issues. I already mentioned right at the beginning that the theatre staff are like an ecosystem. We can't do operations without an anaesthetist, without theatre staff, without surgical care practitioners. And it's really, really important that we are absolutely focused on making sure that those theatre teams can work together. One goes down, the whole lot goes down. No anaesthetist or theatre staff, no operation. We've heard from the Minister about the importance of technology. Again, I'm really concerned that if we have a major cut in funding around this area, that the technology around theatre hubs will also go down, particularly Model Hospital, the whole acquisition of data and the way in which we can actually see what we've done and what we can do. You may have also seen over the weekend a really brilliant technology idea from Maidstone and Kent, where patients are tagged and the beds are tagged, and you can have a kind of master control system and know exactly when the beds are becoming empty and manage that whole thing better. You can't do that without investment. If the money dries up, we can't make our hospitals more efficient. So we need hubs, we need the workforce to go with it. This is a moment of opportunity for the government to really show that they are on the side of the patient. Thank you.
Thank you, Neil. I just want to actually just bring the Minister in on that point on capital and the risk of spending cuts or fiscal responsibility that we've heard reports of in the media. Can we win that debate or that argument around the importance of capital spending in the NHS?
Yes, I think we can. I mean, as you know, the NHS has a very considerable budget. There's always demands for more. But one of the things historically it's underinvested in is capital, whether that's the fabric of our hospitals or in technology and innovation. It would be deeply short-termist were we to meet our day-to-day pressures by cannibalising the funding that we have available to do just those sorts of things. So that I will certainly make that case as strongly as I possibly can. And the government has made a number of, I think, very important commitments, like the new hospital programme, which has been the subject of a lot of debate, but at the heart of it is that simple fact that the NHS has underinvested in the buildings in which we treat patients, and the NHS workforce works in for far too long. And so it is important that we take that forward. And where I've seen examples in my very short tenure in this role of meeting day-to-day pressures by reducing the budget for, say, digital, for example. I mean, there's still 14% of NHS trusts in this country that have no electronic patient records. That doesn't make any sense. We have to fight against that and try to ensure that we keep looking to the longer term, or we will simply miss the opportunity to put the NHS on a sustainable footing for the future. And certainly to address the direct point about the surgical hubs and the similar intervention, which is the CDCs, for the diagnostic centres, they are very much full steam ahead. They play a crucial role in building some extra capacity across the country to tackle the backlogs, and we're going to be announcing the next wave of those very soon.
David, I'll come to you and then we'll finish with Chris.
Thanks, Rob, and thanks so much for the invitation to be here. I think when we look at the sort of premise of the question on the side of patients, clearly we want to ask patients what it is they want from their NHS, and helpfully, very consistently for some time now, they've been saying really three things. So first of all, get those backlogs down. We've already heard some data today, on the sheer number of people that are waiting. We've got a 6.8 million waiting list, up from 4.4 million in July 2019. But then when you look at the profile of that, over a quarter of people now waiting over 6 months, and nearly 400,000 waiting over a year before the pandemic, that could be measured in the hundreds, certainly not in the hundreds of thousands. So, they get that and they want to see action on that. They also want to see action on the workforce. They see that in their day-to-day interactions as well as in the regular reports and the data, and of course getting in to see your GP. They're the three things that consistently come back as we need to see action on that, and I think that the system needs to be very focused on that over the course of the next few years. What do we need to do then to try to drive those improvements? It's already been mentioned before about those kind of dedicated hub sites. We really welcome the commitment to surgical hubs. That's great, but of course in the independent sector you've already got a network of over 400 sites that treat NHS patients to a greater or a lesser extent, and then they're still not being used as well as they could be. Overall activity is around about the same level as it was back in 2019, and if we're to get to that 130% of pre-pandemic levels of activity by 2024-25, which we said we were going to do, then frankly that needs to be a minimum aspiration, and it's great to hear the commitments to maximise the use of that capacity in successive plans, but we need a plan for the plan. We need to get on and deliver that. We need to empower patients, frankly. We need to make them feel that they've got a degree of control in the system. One area of that, for over a decade, patients had a legal right to choose where they get treated, yet still less than half of patients are aware we've got that right. It was great over the summer to hear commitments to, for instance, changing the NHS app by next April to allow patients to choose through that route. There's other things we need to do as well, but it would be great to have that recommitment, I think, to that agenda, because it gives patients hope that there's things that they can do, and recent research that we conducted with the Patient Association showed that if a patient travelled just 13 miles, they could shave 3.5 months off their waiting time at an average across specialties. So not only is it philosophically the right thing to do, pragmatically it's the right thing to do as well, and that's not just at the point of referral, but when they've been waiting for 18 weeks or so as well, so further down the pathway. The Minister mentioned community diagnostic centres, fully supportive of those, and a number of those are run by the independent sector. Our sense, however, is that still some of those, I think over half, are still on trust sites. The C of the CDC, or the first C, into the community, is going to be really, really important as well. So turbocharging that and making sure they're genuinely in communities and seen and feel different to what went before, and not just putting a new front door on an existing diagnostic site is clearly important. And then, we've spoken a lot, about accessing secondary care. We know that pressures are growing in the urgent and emergency pathway, and that's showing up actually in the public kind of mood as well. You go back 10 years, we had a network of polyclinic walk-in centres, places that people could go 8 till 8, 365. Some of those have closed in the last few years. I think we need to give people alternative places to go, so that we're dealing with those that need to be in A&E, whereas those that don't perhaps can be supported elsewhere. And then finally, just from me, let's not forget community services. Again, we speak a lot about hospital-based care in many different ways. Some of the waiting times in community services, which aren't published in the same way, are very, very long for things like physio, podiatry, a lot of children's services as well. That will need a lot of attention over the course of the next few years as well. So plenty to be getting on with, I think, in a busy agenda.
Thanks, David. Chris.
Yes, so what is interesting in terms of the politics of health, I think, is for quite a long time it has existed on a completely different level to the actual policies and implementation on the ground. For Labour, obviously the NHS has always been a get out the vote, rallying cry, a way to scare swing voters. Pretty much the only thing Tony Blair and Jeremy Corbyn ever agreed on was that 24 hours to save the NHS was a winning election slogan. And then for the Conservatives, traditionally it's what they wanted to do on the NHS is just neutralise it, make it go away as a political issue, fall down the salience list, so that people were voting on something where they trusted the Tories more. David Cameron's My Priorities are 3 letters. NHS was the most successful example of that, but I think you see the same impulse in Liz Truss sending Therese Coffey, her close friend, in as Health Secretary to try and sort it out, essentially. What is, precisely because it is now such a problem for patients, the state of the NHS is a serious political issue too. So the question is then, how do you do it? And it's obviously telling that the government has three priorities, one of which is the NHS. But if you look, compared to what it's done on the other two, energy, it came in spending £100 billion, freezing everyone's bills. The economy, massive, huge programme of tax cuts. Compared to that, the package that Therese Coffey announced, although it contained many sound things, was just far less radical and far more incremental than on the other priorities. Although, considering what's happened in the past week, maybe that's no bad thing. So I think one of the reasons for that is because actually, in terms of policy, there really is not much political disagreement. Since the end of the Lansley reforms about a decade ago, both parties have pretty much agreed broadly on health policies, although they don't like to say so for the political reasons that I've just discussed. Simon Stevens used to call it a latent consensus, but now everyone agrees, we need an improvement in primary care. Everyone agrees we need a better workforce plan and more staff. Everyone agrees we need more prevention. Everyone agrees we need more out-of-hospital care. Everyone agrees we need to reform and improve social care. In fact, I think the bigger question really for making this happen is why, after a decade of everyone agreeing on the same things, we've really struggled so hard to implement it. And it seems to me not so much a policy problem, but an implementation problem, just partly to do with the sheer size and unwieldiness of the health service, where you've got blockages ranging right from Whitehall with Treasury short-termism, we've talked about that in terms of capital investment, on one level right down to the fact that if you're running a GP partner running a busy practice, you might think, well, great, I'd love to do digital appointments and have loads of more pharmacists doing routine stuff, but I've got 60 appointments today and my account's due in the evening. When am I going to find time in my day to actually make that happen? But I do think in what Robert's been saying today about acknowledging the reality out there for patients, and in what Labour was saying at their conference last week, where Streeting was saying we can't carry on pouring money into an unreformed NHS, it needs to change, it's not sustainable, there is a sign of that perhaps political alignment becoming closer to the policy alignment, and perhaps that might make it easier to do some of these things. But that doesn't change the practical fact that it is now a very big hole we have to climb out of, some of it to do with the pandemic, obviously some of it predating this. And one of the things that I pick up in the NHS that they're very, very worried about with this new government, and I'd be interested in Robert's thoughts on this, is some people see this talk of being the patient champion as a prelude to a general election campaign when, realistically, we're not going to expect things to have got massively better in the estate of the NHS by then. We can maybe stop things getting worse, maybe make some incremental progress in a few areas, but I think no one is going to pretend we're going to go into the next general election with the NHS in a hugely better situation. So what some people in the NHS are worried about is by saying, the government saying, we are the patient champion, we're on the side of patients, they're then saying, well, you failed, the health blob has failed you, only the Tories can be trusted to sort of sort them out. And I don't see that at the moment, but that is what they're worried about, and I'll be interested in Robert's thoughts on that. We've obviously seen, some Tory backbenchers, David Davis, Edward Lee, others, not people in the government, but people within the party sort of questioning the fundamental model of taxpayer-funded free at the point of use service. You would imagine those voices will get louder as you get closer to the election, and I'll be interested to see how the government responds to that, because I don't see any appetite for them for any fundamental change there, but it is going to be a political challenge to respond to. And I think everywhere in the world is facing the same problem now, which is the demographics are against us for at least the next decade as the baby boomers age, and we have a smaller working age population to fund that, and lower growth. And obviously, Liz Truss' argument is very much we need that growth to fund things like the NHS. I think that is correct. Obviously, how you do that's a different one. But I think it is going to be it's going to be a difficult political argument to make that we are not going to need more money for the health service in the longer to medium term. We've got a sort of very tight spending review over the next 3 years with inflation, and I think the longer term challenge is going to be saying, well, how in the next 10 to 20 years are we going to fund that increase that the ageing population, the baby boomer generation is going to need. I don't see anyone saying we're really not going to be needing that, and it is, but working out how you pay for that and how you pitch the argument about who should pay for that, I think is going to be quite a big challenge in the years ahead.
Thanks. I just want to actually give Robert an opportunity to respond to one thing you mentioned around there not being much disagreement between the two parties on the vision for health and care policy. Are you in violent agreement with Wes Streeting?
Well, I've known Wes for a long time. We were at university together, and we've always got along. I think he did say some very sensible things at the Labour conference. I think the acknowledgement that although funding is important, it's not the only thing that matters to delivering good healthcare to patients is an important one from the Labour Party and might change the contours of debate. I think Chris is absolutely right that the NHS, just through pure demographics alone, is going to require further funding in the years ahead. But we have to find ways of embracing technology in order to put the NHS on a more sustainable footing. And that, I think, is where the long term really does matter, because if you don't try to use the advances in medicine and life sciences, if you don't embrace data and digital, we are not going to be in a position that we need to be for the future of the NHS. One thing I would say on that Chris mentioned about blaming the NHS, there's no sense of that. I think if you look at the tone that adopted by Therese's new health secretary, and I hope by myself, it is to be very straightforward about the challenges that are faced by the NHS right now and not to attempt to sugarcoat those. But I would say one thing, which is that a very striking dynamic is the variability that we see within the NHS. And I think this is where we as Conservatives have a message, which is that we shouldn't be tolerant of those parts of the NHS which are underperforming. And the statistics speak for themselves. 45% of the delays that we see in handing over ambulances at emergency departments across the country are in 15 NHS hospital trusts. Here in Birmingham, 9% of all of the country's patients who are waiting over 2 years for an appointment are here in this city in one NHS hospital trust. Admittedly a very large NHS hospital trust, but nonetheless, there is a degree of underperformance which we need to tackle. And although I personally don't believe that the NHS should be a command and control structure, I think we need to get away from that. I think that was understandably the vision of the NHS at the outset, but it doesn't work for the 21st century, and I think there are too many targets, and we could do with being more judicious when we choose those in the future. I think we will be very clear that we've got to work with those trusts that are not delivering an acceptable level of care for their patients, and really try to raise those standards very quickly. And urgent and emergency care, I think, is probably the most pressing one of those, because we have such a short period ahead of us to get the NHS into the right place ahead of the winter.
I'm going to come out to questions in a moment, but I can see I've got hands poised, which is great to see. I want to ask, we talked about general practice, and we've talked about urgent and emergency care. Elective recovery is one area where we do have a plan, and that was obviously agreed under the Johnson administration, and a lot of extra funding was put behind it. My question to the panel is that plan still the right plan? Can it get us to the destination? And if not, obviously with a new administration in, that's an opportunity to review that. What changes would you like to see? I'm going to start with Neil.
Just to clarify, the right plan for the backlog.
For dealing with the backlog, so bringing the waiting list back to acceptable levels.
Yeah, well, so I think we have all agreed that there needs to be extra capacity. The big stumbling block is workforce. You can have extra capacity. If we don't have the workforce, that's going to be a problem. And you have all heard stories of 40,000 nurses leaving the service despite really, really good recruitment programs. You've heard of many medical staff finding that they're in this world of perverse disincentives over their pensions, and I have colleagues at the age of 52, 53 who are saying, do you know what, I'm not going to carry on, I'm going to leave. We don't know exactly how many are going to leave, but surveys by the Royal College of Physicians and others show that a considerable proportion of the mid to late career medical staff are considering leaving, and that surely true of surgery too. So I think that the targets, to be answering your question, are reasonable, are perhaps doable, but I think it's very, very easily going to be blown off course by 1, restrictions in funding, 2, staffing issues, and 3, let's hope not, but if we have another COVID rise over the winter, we're going to be in a pretty difficult place again.
And just a yes or no question, will we reach that interim target to eliminate those waits of a year and a half? Do you think that will be achievable? Because they eliminated 2 years just about.
Yeah, I'm going to be a good politician. I'm going to say it all depends on the winter.
God, we're definitely not getting anything out of Robert if you won't give a straight answer. We're done for. Deborah.
So very supportive that there have been elective recovery plans in all 4 nations. I suppose what we'd really like to see from Versus Arthritis perspective is a much greater focus on tackling health inequalities. We know outcomes are very variable across the country, as the Minister talked about. I mean, I'd just like to pick up on that point, actually. It would be great if we had some good, consistent data. Actually, it's a huge issue. If you look at cancer data, fantastic data. But if you look at arthritis and MSK, really patchy and variable. So getting a true picture of what you should be targeting and when is really difficult. And I do think that's a very important point to put through. So in terms of elective recovery plans, let's address inequalities. I think we need to do much better about information for people waiting. So there is, of course, the My Planned Care digital platform. Hearing from people with arthritis, people don't know it exists. It's quite limited in the data. And actually what patients are telling us is that they want to know the longest they're going to have to wait, not the average wait, because lots of people are waiting much longer than that. And I know it all sounds very good to give people patient choice, but not everybody can exercise it. If you are older and actually you have caring responsibilities, it can be very difficult to travel to a hospital further away. And how are we supporting people to do that? Also, this approach to digital first with a digital platform to access that information. What about people experiencing digital exclusion, including an awful lot of older people who are stuck on those waiting lists and who perhaps are particularly affected at the moment by cost of living increases as well?
Great. David, and then Chris.
So I mean, I think the plan from February, and much of which was reiterated recently by Therese, is good. There's a lot of good content in there. I think the challenge is to get on and deliver it, and move to a phase where people locally are beginning to see major differences. I think the one thing I would say, in terms of the way in which the plan was structured, is it puts a great deal of emphasis on those very, very long waiters. So we went to try to bring those 2-year waiters down, quite rightly. Now we're focusing on the 78. That's still a long, long period of time within which to wait, and you begin to normalise the kind of long waits that have been entirely eradicated from the system. We do also have to focus on those that are coming into the system and make sure that we have a productivity and throughput approach that gets patients cleared, because if all we're doing is focusing on those really long waiters, that's the kind of service that we'll be having for years to come.
Yeah, I think if you agree that the problem is not an absence of policy, it's an absence of delivering the policy that we have. I think that we need a new plan, we just need to get on and do it. I suppose the political unknown is whether the Treasury efficiency review that's just been kicked off and demand that's gone out to all departments to find savings is going to lead to pressure to reopen any of the commitments assumption in there. I would assume that we would push back on any demands to do that, but I mean, I don't yet know how serious that is going to be.
Well, having been in the job for a few weeks and having reviewed the plans with Therese, the Health Secretary, I think they're strong plans. The origins of the plans were produced before Omicron, actually. And so the NHS did come under more pressure than I think was anticipated immediately after the plans and the funding that accompanied it was set in place. But I think there's every reason to believe that those targets can be met, and obviously they need to be met because that's a key demand of the public, and that's why the Secretary of State made it one of her 4 ABCD commitments. There are some areas I think we can go further. One is pushing more on community diagnostics, and we've talked about some of the innovations there. The lion's share of the backlog actually is diagnostics. There's I wouldn't diminish this because these are important situations that people find themselves in. There's by contrast, a comparatively small percentage of individuals waiting for surgery, the lion's share are individuals waiting for diagnostics. Of course, those diagnostics might lead to further interventions later on. So I think there's an opportunity to push harder on getting those diagnostic interventions done as quickly as possible, and CDCs and so on are a part of doing that. Again, there is variability in the backlog across the country, and so I think there's a task for us to take action and work closely with those trusts that are finding it harder to shift the backlog. But I think that there is a plan in place, and I think there's every reason to believe that we can do it. The winter will be very important, and there's a number of factors at play there, as Neil rightly said. There's concern about a significant rise in flu, which we didn't see as predicted last winter, but may well come back this year. We've seen that in the Southern Hemisphere, and that could have quite a significant impact on capacity within the NHS. There's also, obviously, the unknown as to what's going to happen with COVID, the level of cases, whether new variants might arise. So we will have to keep watching it, but I think Chris was right to say the task is delivery for us as ministers and us working in partnership with the NHS.
So, Minister, yes or no, will you reach that 78-week target next year?
Yeah, I think there's every reason to believe that we can meet that target, absolutely. But there are, I mean, it's not a politician's answer to say that there are some serious factors at play here with flu, with COVID, which are going to challenge the NHS this winter, perhaps profoundly. But what we've seen so far suggests that there's every reason to believe we can meet that. And it is actually important that we tackle those, because these are people who've been waiting for very, very long periods of time. It's entirely unacceptable that people have to wait 1 year or 18 months to get treatment. And so tackling that in the first instance is very important.
I'm keen to draw on questions, so could we please have hands raised? I'll take 3 and then we'll throw them back to the panel. So we've got a gentleman there, and then we'll go to the lady on that side and then the lady at the back. So we'll do that section and we'll come to you next.
Hi there. A question for Robert.
Could you introduce yourself as well,
sorry.
please?
James Illman from Health Service Journal. It's just a question about revenue spending. You seem to make a commitment to not cutting capital spending, saying it would be short-term to do so, which I think will be very welcome to the NHS. But obviously, in terms of inflation, that's meant a real terms cut in the spending review period. So what's going to happen in terms of the shorter-term spending, and particularly ahead of this winter, which you also acknowledged is going to be one of the most challenging in the NHS's history?
Thanks. And then we've got a lady in the third row, and then if you pass the microphone back to the lady behind afterwards.
Hi, Abby Lever from Cancer Research UK. So obviously we've heard a lot about the strain the NHS is under with waiting lists, and the situation is really serious for cancer patients. So my question is, how much focus will the government be putting on prevention measures? For example, reducing smoking, which causes around 50,000 cases of cancer a year, to help reduce that strain?
Thank you. I'm Janet Barter, President of the Faculty of Sexual and Reproductive Health, and actually my question follows on quite nicely from the last one. So whilst we're dealing with backlogs in emergency care, it's also really important to remember that we need to keep people well, and preventative medicine is really important. So over the last 10 years, where we've heard there's been no cuts to the NHS funding, there have been massive cuts to public health funding, and sexual health services, who are funded by local authorities and not by the NHS, in almost all areas of the country have had to close down services. GPs are doing less by way of contraception. And how can we empower women and keep them healthy if we can't even allow them to control their fertility? And just to add on, in the last few months, while sexual health clinics have been managing monkeypox, we've seen a 25% reduction in general sexual health and contraceptive care. So it's even more difficult for women to access this care, which means that they go on now to have unplanned pregnancies. 50% of pregnancies are unplanned, according to studies at UCL. And of course, some of those will be high risk, expensive and dangerous. So please, can you remember those parts of the NHS that are commissioned by local authority?
Great. So just to recap, revenue spending, what's going to be the impact on that in fiscal responsibility? What are we doing on prevention? And then I guess linked to that, the cuts to public health and what's the offer particularly around women's health? So Neil, start with you.
Yeah, I can't really speak about revenue. Cancer prevention, clearly really important, but it takes a long time. An investment now can't be seen in terms of outcomes for a decade or two. Nonetheless, screening and all those other issues have to be taken into account. Prevention and the issues that our third questioner raised, completely agree.
Thank you. Robert, particularly also the question from James, it'd be good to hear your thoughts on.
Well, there's obviously pressures within the NHS budget as a result of inflation. There's pressures in the budgets of every area of the public sector and in everybody's household budgets. That's something that we'll monitor carefully. The Secretary of State has already set out in her first statement to Parliament some extra funding to the front line in the form of the £500 million discharge funding, which is out there already. It's going to trusts and local councils and is going to make a direct impact on one of the core challenges, which is building capacity in social care and enabling patients to be discharged from hospitals faster. So I think that's a sign of our commitment and understanding that where we can, we should be finding ways of putting money in the places where it's urgently needed right now. In terms of prevention, well, clearly that's very important if we want to put the NHS on a sustainable footing. We have to be ensuring that we're harnessing technology and advances in medicine, understanding of public health to try to help people to lead healthier lives. Public funding for public health actually increased a great deal during the pandemic. So it's not quite true to say there have been significant cuts. There were very significant increases in public health funding over the last couple of years, and that's very important. My background, obviously, I've been in local government, and I see the value that public health, when well delivered in communities, makes, and we're committed to trying to find ways of taking that forwards in the years ahead.
Deborah.
Thank you. I'll leave the first one, but I would love to, of course, very supportive of the questions and principles behind prevention. Let's face it, it's absolutely essential that we take a strong stance on prevention for now and the future. At the moment, we have an NHS that is really about crisis management. We have to change this, get beyond party political cycles into a place where we can think longer term and have a long-term cross-government transformational agenda to tackle population health. And there absolutely must be appropriate funding for public health across the country. We should be absolutely using all mechanisms available to us, so we have a real strength in this country around genomics and thinking much more about who is at risk and how we can better communicate risk to people so that they're better able to take steps to perhaps prevent conditions from developing. We also absolutely need to be thinking about the social determinants of health and health inequality. So actually it's really worrying to hear that the white paper on health inequalities might be scrapped or the obesity strategy might be scrapped. So we might suddenly get back to those lovely 2-for-1 at checkpoints offers again. How does that in any way play to an agenda of wanting to have a healthy and productive population who are able to live their lives to the full? And actually, unless we change that, we will never really tackle our problems with health and social care.
Chris, maybe you could comment on the politics around prevention, because there's obviously a clear interaction there, which is perhaps holding us back.
Yeah, I mean, obviously, Liz Truss has made it very clear throughout because she doesn't like nanny state measures, so the sort of more coercive end of prevention seems to be on hold for the foreseeable future, whether that's obesity strategy, who knows, maybe the sugar tax too, and Sajid Javid's disparities white paper seems to be in a bit of a limbo at the moment. I mean, it will be interesting to see if there is a way of, philosophically and politically, a way of thinking about prevention which isn't designed to be coercive, which is sort of about choice, whether that's genomic, giving people more control over their risks, and if there is something that can be set out there that actually will have a real impact. I don't know the answer to that, but clearly that will be an interesting piece of work. But yes, stuff like the buy one get one free, we saw last week at Labour conference. In the while the cost of living crisis is going on, that is not going to happen. No party is going to implement stuff like that at the moment. The sort of further fiscal measures don't see much prospect for that in the immediate term.
David, do you want to come in?
Only to add in terms of the sort of public health side of things, clearly the recent changes, and we've had another slight restructure in the NHS recently. We have one every few years, don't we? So integrated care boards and systems now in charge of planning. I mean, clearly the aim of that is to try to bring public health, NHS services closer together, use population health management, use data better. The NHS doesn't struggle for data; it's how it uses that data. There's data coming out of its ears. So I think they are new early stages, only started in July, but a real test for them that they can try and tackle some of these issues locally.
Back out for questions. So we'll target the middle block now. So we've got a few hands. Can we have the lady at the front? Then we've got the gentleman at the back, and then we'll come to the gentleman in front, and then this gentleman at the front has been very patient.
Hi, my name's Emma. I'm a doctor, a GP registrar in Oxford. On the subject of the workforce problem, I think a big problem is unequal distribution of workforce, a medical workforce and healthcare workforce across the country. And where I'm in Oxford, there's a huge concentration of talent. That's not the same everywhere. Some places are more reliant on international medical recruitment. And I think a part of this is inflexibility in medical training, because in a multi-year training program, HEE, Health Education England's rules are that you need to have some provable life-changing event to change your location. I think it's a great case for more flexibility and liberalisation of that model. People being able to be paid differently, or bonuses for going to work in under-doctored places, being able to keep perks like academic positions. This is only one example, I think, of a lot of generally sort of, you could call lower-level processes which don't hit the ministerial level and considerations, I think, which actually do contribute a lot to the problem.
And so your question is?
What do you think can be done about that?
Great, thank you. Actually, Claire, if we could just go to the gentleman right at the front so we don't have to go back. Sorry, Claire, if you just come here, thanks. And then we'll take the two questions at the back.
Thank you very much. My name's Tony Johnson from Cheadle constituency in Greater Manchester, and I'm concerned about accountability on delegation. Health and social care was delegated to Greater Manchester 7 years ago, and the first thing I was looking for was quick wins and synergies. But I can't get any information on any of that. And what I want to do is to change the focus somewhat to locally to ensure that there's accountability. But there isn't a measure of accountability in Greater Manchester. We voted against having a mayor in Greater Manchester, but it was imposed on the Conservative government by the Conservative government. And we've got the City of Manchester, which is linked, unlike other.
I'm sorry. I want to hear as many questions as possible. So if you could get to your question, please.
Okay. I want to know how we can get accountability and savings made, which are recycled into better services, rather than continually the begging bowl being shaken.
Thank you. And then we'll just pass it to the back, and we've got two questions there. So, gentleman with his hand up at the moment, and then the gentleman behind.
Okay, I'm Alok from Watford constituency. I'm at an age where myself and my family are, users of the NHS, and I have to say that I've been totally disappointed. I've had to either go private, or the rest of my family have gone off to India to get health care. But the question that I have is that one of the blockages I see is the GP surgery, where they're the gatekeepers. What can be done to unblock that so that we can actually start going to the secondary care situation? The other thing is that, I had a pain in my knee. I had to wait 1 month for an X-ray. When I go to the X-ray department, there's hardly anybody there. So the resources are not being used properly, as far as I can see. And also appointments are not being made, and then we get cancelled because apparently we didn't turn up to an appointment that didn't exist. So there is something radically wrong with the administration of the NHS, which needs to be looked at. What can be done about that? And finally, in regards to staff retention, I would say that NHS has quite a reputation for a bullying culture, and a lot of stress, and the staff vacate as a result of that. And also the pension problem is a serious problem that should never have happened. What are you going to do about all of those?
This is the problem when you give people the microphone. Could the gentleman at the back please ask your question in one sentence?
Hi, I'm Ben from AstraZeneca. Is the new administration planning to continue with the life sciences vision or rethink the policies in it?
Brilliant. Okay, so just to recap, because we've taken a few there. So the unequal distribution of the workforce, how do we potentially change that? Rules around HEE. What are we going to do about accountability, particularly when it comes to devolution? The Greater Manchester example, has it delivered the sort of return or dividend on health and social care that we want? The role of going private and the sort of opt-out, is that taking on? What do we do about gatekeepers? And then delivering the life science vision. So perhaps I'll ask the Minister to respond first.
Right, well, goodness me, there's so many questions there. Let me answer as many as I can.
And I think we'll have to summarise as well, probably, because we're just coming up to time.
Understood. On the workforce, you're absolutely right that it is unequally distributed. I mean, that is one of the arguments for more domestic training, because we've seen where those new medical schools were created under Jeremy Hunt's tenure, a place like Lincoln, near to where I represent. If you train somewhere, you're more likely to stay there and put down roots. Otherwise, you may end up gravitating to some of the big cities and teaching hospitals like Oxford. In terms of retention, that's also very variable. I think the trust, for nurses, the trust with the highest level of churn experienced over 30% churn a year. The one with the lowest is, I think, 5 or 6%. So there are significant differences there as well in terms of retention and the strategy. We are working on that. You say it's not something that comes to ministers. I had a conversation with the chief nurse last week about it, and we're trying to put in place plans in each trust to try and tackle those issues. In terms of devolution, in general, I'm a supporter of devolution. I did so as local government secretary. With devolution must come accountability. And you've got to ensure that we have the data, and you as councillors and as citizens can understand what's happening. I don't think that always happens. I saw that in a very prominent incident with the Mayor of Manchester during the pandemic, where all of the NHS professionals were telling us that their hospitals were going to be overwhelmed because of the pandemic, and yet it took a very long time for him to concede that actually there need to be further interventions in Manchester. And so if you're going to have responsibility, you've got to, for healthcare, you've really got to have accountability for it and feel that accountability. And I think citizens have to be able to hold them to account. We've now created ICSs and ICBs in other parts of the country, and we have to make that model work. And we need to hold the individuals involved in those to account. In terms of GPs, Therese, the Health Secretary, has made this one of her key priorities. We've already put in place a number of tools to help them over the course of this winter and beyond. One of those things is around greater access to community pharmacy in the first instance, and I think that's a big opportunity to reduce the pressure on GPs so that we can make use of community pharmacies where we can. And the point around the appointment system generally, whether that's for GPs or for the NHS for managing waiting lists, there's a lot of work that needs to be done there. That is generally poorly managed. We've put in place further resources and technology at the disposal of GPs to help them manage that. And I think there's a piece of work for us nationally to look at the waiting lists and see, is this being managed correctly? How do we define that? And so on. And then lastly, with respect to the life sciences vision, well, we couldn't be more committed to that. If we were going to add an E to ABCD, it would be economic growth, and life sciences is probably the most exciting area of the British economy today. There's huge potential. I know Therese feels very passionately about this as well, and we want to take forward the life sciences vision with vim and vigour.
Great. I'm going to go to Neil. If we can try and keep them fairly short, because we're just coming up to time. Thank you.
Just on workforce, clearly we haven't mentioned training. No training today, no surgeons tomorrow, so I'm completely in step with that. There is very good evidence that if surgeons train in less, if you like, popular parts of the country, they'll tend to end up on the staff there. So that kind of redistribution is going on, and I'll leave others to answer the other questions.
Deborah.
I'm not going to answer any of the questions. I'm going to, if that's all right, I'll just give a bit of a sum of what because I think it picks it all up. So I think what we need to be doing here is having an emergency plan for the next 6 months, making best use of all resources, including making sure that we're incorporating the resources and support of the voluntary and community sector. I think what I'm hearing very much is we need the big decisions to put the NHS and social care onto a much more sustainable footing. That has to include a proper, fully costed, implemented workforce strategy. And we've been talking about this for so long. We really just need to get to implementation as well with some quick decision makings. And I think we absolutely need to have a transformation agenda to tackle population health that goes beyond individual party political cycles and into actually thinking about the health and well-being of our nation as a whole.
David.
Just on a couple of those points, I mean, Emma's point around unequal distribution of workforce, it's always staggered me that the National Health Service, the end bit of that, makes it very difficult for people to move around, actually, in the system. We find in the independent sector people coming to our side of the aisle, as it were, and often because they feel it is easier to move around within a national chain than maybe it is within the National Health Service. So that's certainly curious. Alex's point about private, I mean, we're certainly seeing a growing number of people choosing to pay privately for healthcare. I don't think that should come as a huge surprise, but frankly, the ambition here has to be to make sure that high quality care free at the point of use is available to all, in addition to supporting those that wish to choose to go privately. So that has to be the focus. And on accountability, I think it's a really key point. You know, the ICBs, you know, are now responsible for moving forward the agenda that's been described in the varying plans. There's 42 of them. They're huge budgets. We need openness and transparency in what they do.
Chris.
Yeah, just 2 points. I mean, on workforce, a decade ago, this was not something that anyone talked about. You know, you had to be quite far into the details of health policy before people started talking about workforce and training. You know, that has changed over time. And you saw last week at the Labour conference, they made a promise on training, their headline policy on health, although I think they're going to have to find a new way to pay for that now. But that is going to provoke some. The government is going to have to respond to that in some way. So I think it is finally becoming a top-level political issue, and I think that does mean that eventually, sooner or later, something serious will be done about this. And just on the point about efficiency and wasting patients' time, I think it is something that patients, anyone who uses the NHS, it has stories of tearing their hair out at the inefficiencies, but that is not something that can be solved politically from Whitehall, other than to say the problem there is that, local managers just have no incentives to put any value at all on patient time. So you need good managers with the right incentives to do that, and not the wrong incentives of being distracted by pointless, the wrong targets instead.
I'm afraid I'm going to have to bring it to a close. I'm sorry if we weren't able to bring you in. Just a brief plug, we've got 2 more health and care fringes coming up. So tomorrow at 1 o'clock, our Good Jobs, The Secret to Good Health with Victoria Prentice from DWP. Obviously, we talked about the economy and the growth agenda. And then in the evening at 6:15, we talked about health disparities. We've got an event with Dr. Caroline Johnson, who's one of Robert's colleagues in DHSC, on does the Conservative Party have a plan to address variable outcomes in England. So hope to see you there. Thank you very much for joining, and please thank our panel.